That's a very broad question because you've said ICTs in health. So we're looking at the full spectrum from in fact data gathering, data storage and in fact analyzing data, to telemedicine, to in fact raising the awareness and in fact education of people. It is essential in the developing world, but the problem is that within the developing world, the actual infrastructure is very poor. The costs are in general very high. India is the exception. Because you've had this ICT boom, as it were, in fact, you have managed to bring and actually develop the capacity of a large number of people in the ICT industry. So you've got bright young people programming and in fact developing. You've done some excellent things in India. You've kept the cost of communication down to an absolute low. In sub-Saharan Africa, the costs of broadband access exceed the GNI per capita in many countries by a factor sometimes up to 7 or 8 times the GNI. Broadband access. Fixed line 0.1% in sub-Saharan Africa. Internet access 4.5% to 5% in sub-Saharan Africa. In South Africa, we are functioning at about 11% internet access. At least, yeah, in fact, total internet penetration. The cell phones, in fact, you have managed to keep the call cost down to a ridiculously low level. I don't think you actually understand how fortunate you are. Cell phone costs in South Africa are about 5% of the average person's income, or it's 5% of the monthly GNI, compared to in the States about 0.8%. I in fact don't have the figure for in fact India, but I've been startled by the ads I saw on TV last night for how cheap 3G access is. Back home, I'm paying for 1 gigabyte of data 3G. I'm paying about, I've got to get my maths right now, about 2,100 rupees a month. And that gets me one gigabyte of data. Cell phone calls a minute, we're charged about 15 to 20 rupees in fact 3-minute call. So you can have a sense of some of that. But the general information and communication technology in health within Africa, we desperately need it. We need it sooner than later, but we're faced with the problems of infrastructure and cost. And something else that we're faced with, which I don't think you're faced with here in India, is that many of the donor nations who are funding projects, be it in TB, malaria, HIV/AIDS, all have set up their own data gathering systems and are effectively silos of information, with people having to gather the same information into each silo. So much so that some countries, and I think of in fact Uganda, have begun saying to funders, we will only gather one set of data. We won't gather 17 or 18 sets of data because of the extreme shortage of health workers. There are 31 out of the 48 sub-Saharan African countries have 10 doctors or fewer per 100,000 people, which is significantly less than you have here in India. And all of this data gathering is just extra work. But we also have to remember that telemedicine itself is extra work, because you're adding extra steps into the normal workflow of people who are already overburdened. And I have a problem. I'm having to do extra work to get the problem to you, so I'm making extra work for you, and you are going to have to do extra work. So somehow we've got to look at how we can task shift in this whole process and get other ways of doing it.
So what is the role of your organization?
Sorry, I can't hear you with that.
What is the role of your organization in improving health scenario in South Africa? What are your new initiatives and what are your future plans?
Okay. I'm fortunate. I have the only academic department of telehealth within sub-Saharan Africa. So we run postgraduate programs at diploma, master's and PhD level in both medical informatics and in telemedicine. So that is our education role, but we see our education role as being far greater than that. From the bitter experience that I've had of having to set up these postgraduate programs, in fact myself, I understand how difficult it is for people in the other African countries. So with funding from the government in the States, we are attempting to duplicate our medical informatics program in Zimbabwe, Uganda, Mozambique, and so I was saying that we're attempting to build a capacity in other tertiary institutions in other African countries that over time their staff can then offer their, in fact, own tertiary degrees. But at the same time, we are sharing teaching between the different institutions. But there is far more that has to be done in terms of capacity development. There is both, well, there are in fact three things. You can educate, you can train in specific areas, and you can build the awareness. Now, certainly with, in fact, in South Africa, we've been working on establishing basic telemedicine services, but you have to understand the context in which we work. In 1998, the National Department of Health launched the National Telemedicine Program. They were very far-sighted. Unfortunately, for various reasons, that program failed. And it's taken us nearly 10 years to overcome that failure. Of the 9 provinces in South Africa, and it was only until very recently that the provinces actually assigned posts for telemedicine. There are very few provinces that actually have a budget for telemedicine. So it's been the tertiary and or institutions and the medical schools. It is the, in fact, the medical schools normally that have been involved, and then of the 8 medical schools, there have been very few that have been involved. But having said that, there has been a change in the, in fact, Ministry of Health, and the incumbent minister is very set on making telemedicine work. He has identified this as a national priority. The state president has identified it as a national priority. And there is an advisory committee to the minister now on health technology, one section of which is on telemedicine. So we expect fast progress. For example, there is no telemedicine strategic plan. There is a draft, and we hope to finalize that certainly within the next, in fact, 3 to 6 months. We hope that the e-health strategic plan and policy is finalized within the next 3 to 6 months. Because then at least the different provinces have a roadmap. Within Africa as a whole, there was a meeting called by the African Union, I think it was in April of this year, where they invited so-called e-health experts from in fact all over the world to attend, to begin the process of harmonizing e-health and telemedicine within Africa. Now, the word harmonizing is interesting because it suggests that there will be a sharing of ideas, a sharing of thought, and probably a sharing of services over international boundaries. Now, there in fact is only one group that have successfully looked at doing business internationally over boundaries. Yes, I understand that in India, people are sending x-rays from the States and they're being interpreted here. But within the EU, they now have law that allows payment for services in health from one country to the next, and they're finalizing the service, so telemedicine. So if I happen to stay in France and I'm in England and I'm sick, I can be treated by my doctor in France while I'm in England, and the insurance company will pay for it and it will be accepted. These are the type of goals that we have to aim for within Africa. With the extreme shortage of doctors, we need international help.
Yeah. Sir, according to you, what should be the roadmap to achieve the goals of health access to all in South Africa and India?
The in fact issue of health access for all is a very difficult question. One needs to understand the extreme level of poverty in both countries. The slums here, our informal settlements in South Africa, they're essentially the same thing. We need to understand that and work knowing that these are the poorest of the poor, the people that we have to be aiming at in order to improve the health and ultimately the wealth of the nation. And I think that most of us, when we set up services, we tend to go for those services which are comparatively easy to do in the first instance, so that we can show success. We aim at the middle income to just under middle income people who we can show benefit because they've got transport, they can come to a hospital, they may have a phone, etc., etc. But if we are to truly be successful in this, we really have to remember that it's the poorest billion people out of the 6.5 billion people in the world that we should be aiming at. Now these people often have no fixed address, so we actually can't get to them in normal ways. Many of them can't read or write. They may have access to a cell phone through a neighbor's neighbor. So somehow we've got to conceptualize how we get to them in order to make this work. And I think that the concept of centers is excellent.
We are starting with a session on public safety, security, disaster management, convention hall H2O. Master Literacy in Chanakya Hall, please. Settle in these halls, please. Thank you.
So I think that we in fact need to make certain that in our planning, we don't plan at the level of district hospitals and regional hospitals and the in fact larger health centers, but we conceptualize how do we get the poorest person a service, and is that service going to be at in fact his or her doorstep? Is it going to be on a phone? Is it going to need them to come somewhere that we can do it?
Sir, according to you, what kind of re-engineering is needed for effective implementation of ICT in South Africa?
Sorry, I didn't get that.
Sir, what kind of re-engineering is needed for effective implementation of ICT in South Africa?
Look, I think that the in fact ICT market in South Africa has been stable for some time. The in fact re-engineering, if indeed one can call it that, is to end up with a situation where specifically for health information systems and electronic patient medical records that we have standards that are being followed by everybody, but I think that is largely addressed by in fact international groupings. But the issue becomes in fact interoperability. How do we move the data from one person's system into the next system? In South Africa, we have a very large government-driven program for a national health insurance. The full details of that have not yet been made widely known. But it would seem that a health information system and an electronic patient record is going to have to be an integral part of any national health insurance scheme, because people are going to have to be able to access data from, in fact, anywhere in the country. So where I stay in Durban, if I go down to Cape Town for a conference and I fall ill, they're going to have to be able to access my data from Durban. Now, I don't know how much of that is re-engineering, but it's actually making certain that when the standards and the specifications for a national health information system are set, that they take all of these into account. And it isn't a problem only in South Africa, it's a problem everywhere in the world, especially in the most developed countries which have had these for many years. They've got vendor 1, vendor 2, vendor 3, all with a different solution, and it's how do you get the information shared. The next issue is it possible in the poorest countries to do this in an open source way?
We are starting with the sessions. Please request you to kindly settle at these halls.
So one needs to follow with interest the...
We are starting with the sessions for public safety, security, and disaster management in Convention Hall of Gajor and RCT Mass Literacy in Chanakya Hall, Samraj. Please assemble at these halls. Thank you so much.
The whole open source area needs to be followed with interest. You've got an international grouping called Open MRS, Open Medical Records Systems, who are doing excellent work in different parts of Africa, building on a modular basis open source health information system solutions for the projects they're working on, but with the idea that one can take the modules over time and mix and match. Now, there is always the issue of open source. Is it going to be sustainable? Who is going to, in fact, guarantee that everything works? Who is going to continue upgrading? But certainly within the developing world, and I talk specifically of sub-Saharan Africa, where the average spend per capita on health by government is about 75 US cents a head a year. Now, that's on health all told. Now we've got to take a bit of that and we've got to put that into ICT. So we've got to be very careful of how much money we put into ICT, because the money we're putting into ICT could be taking tablets out of the mouths of sick kids. So one needs just to bear all this in mind, and if there is a message that I constantly put out, is that we don't know enough about the economics of e-health. It isn't just in India, it isn't just in South Africa. Internationally, we don't know much about e-health economics. We don't have frameworks, we don't have guidelines, we don't have set metrics, we don't know how to do it well. So in terms of ICT in the developing world, we need to leave the hardware, the programming, and just stand aside of it and actually understand the economics of this so that we can guide the process better.